Thanks a lot, Marty, and thanks for having me. I had honestly great days yesterday, meeting the PIs, having a great discussion with the fellows from Peter's lab in Bladder, then having a great time with the residents. So we have had quite a lot to see. Justin here, who came from Toronto, Hature is with us now, and Paul Torrent. So there has been a little bit of cross-contamination between Toronto and UBC. Thanks certainly for the invite. I was very impressed so far. So these are my disclosure. Actually, none are relevant to the talk, and I just would like also to thank Verity, who has been supporting my trip here, so I can be with you. The first disclosure is I am not a radiation oncologist. I'm a surgeon, like you. And so although I'm going to talk about radiation and chemo radiation, I'm a surgeon. And I'm, like many of you, an MIS, which for me is a maximally invasive surgeon. And I use min incision. And so basically, you're going to have a surgeon talking to you about bladder cancer, muscle invasive bladder cancer, and just maybe shaking some of the concepts that everything should come out. And so the entire goal of this morning is to rethink radical cystectomy as the only choice for patients with muscle invasive bladder cancer. I also have to say that I had yesterday, so some of the slides, you'll forgive me, are not completely perfect. Yesterday morning, I had the experience that I was fearing for years and years and years, which is you go through security at Pearson or here, there's a long lineup, and then you have an angry person at security who tells you to remove your laptop from your small bag to put it in a separate bin. And then you have a lineup of dozens of people at the scanners. The scanner doesn't work. And then you see your laptop going and you're still staying and waiting. And then you go to security and what you find is a laptop. But hey, it's actually not your laptop. It's someone going through Vancouver with another flight to Korea. And so basically, finally, by miracle, they found the person. He got his laptop, but my laptop was in Toronto. And so my team sent my presentation, which was a draft. So there are going to be a couple of things that I'm going to discuss with you just orally rather than on the slides. Good. So radical cystectomy has been the traditional gold standard for MIBC. And this is clearly not a mini incision. Sometimes we've done super extensive lymph node dissection. We're all surgeons and we know this. And I think we have done improvements in terms of management. This being said, we have to acknowledge that there has been a paradigm shift in the treatment of many organs, rectal cancer, ENT, you name it. And that has gone towards organ preservation, where you really combine a limited surgical endoscopic resection with chemoradiation. This has been termed trimodality therapy. In muscle invasive bladder cancer, the same concept has applied. And the concept, although we can discuss about it, combines a complete resection of the macroscopically visible tumor. So basically, you leave chemo and radiation deal with microscopic cells rather than macroscopic cells. And usually you use RT with a chemosensitizing agent to improve the efficacy of the RT. And TMT has emerged as the most robust approach for select patients with muscle invasive bladder cancer. And when I say select patients, usually these are unifocal tumors, less than 7 centimeters or 5 centimeters, just because you have to be able to completely endoscopically resect them. No extensive CIS, because CIS at the end of the day is a surrogate for genetic instability at the mucosal level of the bladder, so that if you leave the bladder, by definition, people are at risk of having a recurrence. And so you want to minimize the setting where this would happen. No extensive CIS, with the assumption that, as we discussed yesterday with the resident, it's also all the time, most of the time, actually an understaging if you have an extensive hydronephrosis. And in order to preserve a bladder, you have to have a good bladder function to start with, because if your bladder function is actually terrible, it's not that's going to be improved by TMT. Now, in 2008, although this had started before, we have every week our multidisciplinary bladder cancer clinic, and Peter came to us when we had one of the events where on a regular basis, we actually showcase how it works and also discuss cases. And this multidisciplinary bladder cancer clinic is especially for complex bladder cancer cases, and where patients have and their families are offered different type of treatments with the different teams at the same time. And so participating are the Uro-Oncs, one Uro-Onc every week rotates, Rad-Oncs, Med-Oncs, clinical coordinator, PAs who help, pathologists, because every single of those cases discussed at the multi-D are actually reviewed initially prior, so that we make sure that we discuss about the same grade and staging and the variants, and of course, our pathologists and nurses. And this allows a simultaneous assessment by the different teams. The radiation oncologists come with us and scope the patients. The medical oncologists are there and discuss, so that basically there is an improvement in the knowledge of all the specialties, which ultimately, hopefully, can actually improve the management of the disease. And the way it works is that we look at all the images, look at the pathology, discuss among ourselves, have a discussion among the group whether patients are eligible for TMT, radical cystectomy, both, or some other type of treatments. And then we discuss simultaneously with the patient and the family the different options, pros and cons, and they come up. And this certainly offers the opportunity for additional investigation and also inclusion in clinical trials, which truly are of utmost importance. We also are helped, and I showed that yesterday, by something that was spearheaded by actually Mike Jewett, which is the bladder cancer computerized system, where you have the entire story of the patient that develops in front of you. Anything which is green is basically, it's negative, cytology negative, a CT negative. You can see the number of installations. You can see when and people had recurrences. And it's actually probably making our life much easier. You can actually click, and then you see the image of the previous cystoscopy. You click, you see the pathology. And so this has really been something instrumental in the development of the multi-D clinic. The technique itself for radiation also includes the injection after the resection prior to commencing the radiation therapy of fly-idle. Why is that? Is that by definition, a bladder is mobile and also can be over-distended, less distended. And so what we do at 1 centimeter from the crater of the tumor that was previously resected and which is amenable to TMT, we inject a couple of 1 millimeter, like a little bit Teflon or others, in the mucosa. Then you can see it on the CAT scan, and this allows to have the delivery of the maximum dose on the base of the tumor, and then spare a little bit the rest, still delivering a dose at the entire bladder level. We also, and that's one question that very often comes up, we also treat the nodes. TMT also requires a very stringent follow-up. And the reason I'm saying is that I'm going to present data comparing TMT and radical cystectomy, but one has to understand that it requires a lot of people. It requires a very stringent follow-up. And so it's a little bit more difficult than simply saying, oh, it's the same and equivalent. There's a lot of work to get there. And as you can see, if you keep a bladder, you have to pull on the trigger of the recurrence early on to offer the same kind of survival. And that requires cystoscopy every 3 months for the first 3 years, and then every 6 months for the 3 following years, and lifelong cystoscopy follow-up. And as we know now, TMT is part of the NCN guidelines. That's a slide that was kind of given to me by Wes. And when patients are actually with too many comorbidities, you can combine it sometimes only to RBT, as you know, or chemo and radiation. So no doubt that has been a growing body of evidence about the efficacy of TMT, and it's accepted by guidelines, but it has been restricted most of the time to patients with significant comorbidities for whom surgery was not an option. And one possibility was that there has never been any randomized and comparative study, and therefore, as long as people don't have a study comparing those two, it's difficult to come up with a robust conclusion. Let's be realistic. Ain't gonna happen. The SPARE trial closed. There's another trial in San Antonio that closed. I don't think that in the next 5-10 years, there's gonna be a randomized study comparing those two. And so this is why, in the absence of level 1 evidence, discussing with Jason F. Satuit at Mass General, discussing with Zia Danishmand, that you all know, of course, at USC, trying to get advantage of our MRTD clinic and trying to come up with something that ultimately still would allow us to compare the two modalities, we actually came up with this study that was published a couple months ago in the Lancet Oncology, and where we decided to merge the experience of USC, Boston, and Toronto, and to compare apples with apples as much as one can using a multi-institutional propensity score match and weighted analysis. So to do so, we included 722 patients at those 3 institutions, T2 to T4 clinical, well, I'll show you the breakdown, 440 radical cystectomies and 282 trimodality therapy. And we included patients who went through the clinics at Boston and in Toronto and who would have been eligible for both treatment options. And the patients included had solitary tumors less than 7 centimeters. We can discuss 5 or 7. No or unilateral hydronephrosis, a little bit what I showed you, and no multifocal carcinoma in situ. And so the first question that everyone would say, okay, fine, but out of all patients who walk through the door with muscle-invasive bladder cancer, how much does that represent? In our experience, actually, this did represent roughly 30% of patients equally in Toronto, LA, or Boston. And so the first thing I want to emphasize here is that what I'm going to present is for a subset of muscle-invasive bladder cancer, not for all patients. In order to try to balance group, we use treatment propensity scores. Many people have used that. And we incorporate them with a 3-to-1 matching, but also the well-described EPTW, the inverse probability treatment weighting, which is another way to balance groups when there's imbalance to start with. We use several endpoints and not only one, from overall cancer specific, distant metastasis-free survival, met-free survival, primary endpoint being upfront met-free survival. And these are all the covariates that we use to match patients, including BMI, the presence or absence of neoadjuvant or adjuvant chemotherapy. We also did an intent to treat, and I'm going to show you why that is important. So everything was an analyzed intent to treat, and by definition had also sensitivity analysis. I'm going to show you the outcome of this comparison between RC and TMT. Interestingly enough, we had decided up right off the bat to have the 2 teams of statisticians in Boston and Toronto completely blindly to each other analyzing the results. And we were actually reassured to see that the 2 teams found exactly the same thing, a little bit different methods. And it's only when we saw exactly the curves of each of the endpoints being exactly the same that we actually merged the analysis in one single analysis. This is the classical table 1, and where you can perfectly see that before matching, by definition, you will not have a balanced group. We're not in a randomized setting. But what you see is the also classical curve after matching, where at least the parameters that we had actually included are actually then balanced. And overall, median age not out of the norm, 71-year-old, 75% of men, again, very classical. 10% of hydronephrosis, which means that 90% of those patients had no hydronephrosis. 90% of clinical T2, and we can debate how inaccurate clinical staging is, but still it means that we're not dealing with clinical T3 disease. And 60% had either neoadjuvant or adjuvant chemotherapy. So that was a selected group of patients who were exposed to additional chemotherapy. 60 is probably what level 1 evidence should show, but it's not necessarily what everyone. Do you have any idea, Peter, how many patients here get neoadjuvant chemo in radical cystectomy, generally speaking? 50. So basically in the same ballpark as this. Okay. And so our first primary endpoint was med-free survival. And whether you use propensity to score matching or IPT-TW, you can perfectly see that there was absolutely no difference between TMT and radical cystectomy at 5 years. Adjusted cancer-specific survival, exactly the same thing, absolutely no difference. And I also would like to draw your attention to the fact that, and I'll show it later, with a cancer-specific survival north of 80%, both for surgery and TMT, actually these were really excellent results, really excellent. I do think that we've gone a little bit, we've improved over time, even for cystectomy. Now, this has triggered quite a lot of discussion and debate. There was an imbalance and an advantage in overall survival for TMT. There are two explanations possible. One is that we considered, first of all, there was a mortality, perioperative mortality in the cystectomy cohort of 2.5%, which accounts right off the bat. And there was also something that I personally think was completely due to pure chance. In the first year in one of the TMT cohorts, no patient in this age group died of anything. And okay, you expect a couple of those men with comorbidities to die, and it's possibly one of the reasons. Now, another question would be, okay, but can you compare patients who received neoadjuvant and RC versus TMT? So absolutely everyone has actually received chemotherapy. And as you can see here in this sensitivity analysis, whether it's med-free survival, cancer-specific survival, or disease-free survival, there was absolutely no difference. Now, remember,
we see you on video.
The beauty of Zoom. Now, you remember I told you that the outcomes were analyzed as an intent to treat. And basically, what that means is that 13%, 1/3, of patients who initially were in the TMT cohort ultimately required a radical cystectomy because they had a recurrence, which was invasive, and where you had to do a cystectomy. And so the first thing is when we say TMT and RC provide exactly the same outcomes, yes, but this is pending that people understand that they have 10 to 15% chance of ultimately, despite being in the best candidates, a tumor recurrence that prompts and requires a cystectomy. The silver lining, though, here, and the reassuring thing is that if you follow patients close enough, you monitor them every 3 months, you do CAT scan, and you pull on the trigger of the salvage cystectomy on time, you can see here that actually whether patients required a salvage or were treated with TMT alone, there was no difference in terms of survival. And so that means that radical cystectomy salvage and the role of urologists is absolutely central as well in TMT. And it's not that you're going to treat patients and then you don't follow. If you do so, you're going to have way worse outcomes for TMT. then the second question, and that's why we did this multi-institutional study, was, okay, but are there differences between centers? Yesterday with the residents, I talked about differences even for non-muscle invasive bladder cancer between surgeons. And here what you can see is that whether patients were operated in Toronto or LA or treated in Boston or Toronto, there was absolutely no difference between centers, which again was kind of reassuring about the generalizability of the data. So as I mentioned, the equivalence in outcomes were pending that everyone understands that 13% had to have a salvage cystectomy. There was one cystectomy actually due to complications from the TMT. So to mention that it's rare, but it also has to be brought up to patients. But that's the other thing, which is kind of interesting, and I think it's really worth looking into the lab and understanding. What's fascinating is that you treat a patient with a high-grade muscle-invasive bladder cancer. You monitor this patient, and 20% of those, in addition to the 13% who have an invasive tumor requiring a cystectomy, 20% will present with low-grade disease TA. And I find fascinating from a mechanistic point of view, in the past, we didn't know, because you had muscle-invasive bladder cancer, you take the bladder out, so what do you know what's the future in the bladder? And here, it's kind of fascinating to think that the genetic hit that initially hit the bladder to get into the high-grade pathway and invasion is taken care of. And then the only type of tumor that some of those patients is actually a TA low-grade. We're going to have a look into the genetics, whether it's also driven by FGFR3 and those kind of things. But I find that fascinating. There was an excellent question yesterday as whether we could think that by delivering some radiation on the entire bladder, we kind of get rid as well of some of the higher grade, and that's why they develop only the low grade. But that wouldn't fit into the knowledge that we all have that in carcinoma in situ, actually TMT is not effective. And so there's something fascinating about the initial hit, and we perfectly know that when you biopsy a normal-looking mucosa, even bladder cancer, you're going to have genetic mutations. And why is that some go towards the low-grade pathway, although they had the same event? Really fascinating. So the second thing is that the radical cystectomy series was completely classical. As expected, we had 44% of PT3, and we had 26% of node positive. And also as expected, PT2 without hydro fared better than PT2 with hydro, fared better than PT3, and fared better than PT3 with hydro. And so the reason I'm showing that is that there was nothing unexpected, unusual about the series, where what you were expecting in the radical cystectomy series to be observed was actually observed indeed. We had a perioperative mortality of 2.5%, median node removal of 39, with Seth Lerner's study, as you know, where he shows it doesn't really matter, but at least that it was often considered a surrogate for the surgery. Positive surgical margins of 1%. And in the cystectomy series, a cancer-specific survival for 26% of node positive and 44% of PT3, of 83%. And so the reason I'm showing that is simply to show that by no means the equivalence between TMT and RC was due to a suboptimal outcome in the RC cohort, far from that. And I also do think, I was actually very impressed, I do think that as surgeons, we're doing better. I'm not too sure why we do, but I definitely think to a certain extent, we're doing better. So there are definitely strengths, but there are also definitely limitations to the study. The strengths are these large multidisciplinary and contemporary series, using multiple relevant endpoints, not only one, using independent statisticians with multiple sensitivity analyses, with very reasonable and decent outcomes in surgery and TMT, and a consistency between the different centers. But The best propensity match analysis will never, ever replace a randomized study. There's still potential confounders. It requires a lot of manpower to do that in centers who are performing seamlessly post-RT salvage cystectomy. It requires a rigorous follow-up. We all know that the tumor size is notoriously, as well as clinical staging, imprecise. And our median follow-up was just short of 5 years. So, and we also didn't have any cost analysis. The current future studies that we're building up on this one is to look at the influence of immortal time bias, because people have actually to go through the treatment until, and then it may introduce some degree of bias. We've already looked into it, and we don't seem to find any differences, but it needs to be fine-tuned. We also have a conditional survival, because people have to live up to a certain point to be censored. And then we're also looking now with the statistician into these potential confounders. And the third thing is, and I'm absolutely not an expert, far from that, several groups now have used pseudo-randomization. And so they basically use data set to literally pseudo-randomize data sets which originally are different, with techniques that have been recently published. And so I think the next step will be to reanalyze the entire data set using new techniques, again, to try to minimize, to make sure that whatever we found is actually holding true, even and with more scrutiny. And so the conclusion here was that we believe that probably this study provides the best evidence possible in the absence of randomized study, supporting TMT as a very efficacious option for select patients with muscle invasive bladder cancer with equivalent oncological outcomes. I emphasize that time and again, this study does not support that RC is not a good option. It's actually an excellent option. I showed you the cancer-specific survival. What the study shows is that we as surgeons have to understand that it's not the only option, and there are other options now, truly, which can be supported. And we believe that, and that's what we practice every Wednesday, is that TMT in the setting of multidisciplinary bladder cancer clinic should be offered as an effective treatment to all suitable patients, including younger patients, and not only to patients who are not candidates for surgery. I'm gonna move on with the second part of the talk. This is bladder preservation, where you resect the tumor and you give chemoradiation. But the ultimate bladder preservation is actually where you give neoadjuvant treatment, you achieve and you are able to confirm a PT0, and you basically consolidate with nothing. That's going to be truly the future. We're not there yet, and I'm going to share a couple of slides and discuss some that I didn't. And I really, what I'm going to try to show you is that I think that bladder cancer is prime now for what Marty has done for prostate, for instance, a bladder cancer GUNS trial. We have moved a long way in terms of understanding the biology of the disease. We have now a couple of very efficacious treatments, and we should basically tailor, rather than having one size fits all, get a sense using also the genetic landscape of the tumor to try to pinpoint those patients who may not even need any consolidation. I'm sure that all of you are aware of the Abacus and the PURE trial that was using atezo or pembro prior to cystectomy. As a reminder, in the Barton Grossman New England Journal of Medicine, the PT0 was actually 39%. So this was fairly high. Usually it's hovering between 20 and 30%. And in that trial, as you know, 68 patients for Abacus, 50 only for pembro. Oh, interesting. The primary endpoint was complete response. And if you look at the complete response rate, don't do anything, it just moves. Just there's a ghost. It's Halloween. what you see is that single agent IOs provide here for pembro 40% of complete response, atezo a little bit less, but it's not dramatically different from what neoadjuvant chemo can actually provide. And so that's why we're going to be moving more and more towards doublets or triplets. And as I mentioned, the ultimate bladder sparing is actually the absence of cystectomy or TMT. There are multiple trials ongoing, and this is a table, but I'm gonna also discuss the recent data from Tom Poles. Retain 1 with MVAC, Retain 2 NVAC and Nivo, one by Matt, GemCis plus Nivo, and dose dense GemCis versus GemCis. And so most of them have composite endpoints, complete response, but also med-free survival. And they all use biomarkers. The most well-known is RCC2, and I'll explain why in a minute. But there are many other of these mismatch mutation and repair genes which are investigated. One of the most promising was alteration in RCC2, and then there was initially in New York a nearly black and white picture that patients who had that mutation had 100% response and complete response to neoadjuvant chemotherapy. This is a slide given to me by Betsy, where in validation, it lost a little bit of its strength. But unfortunately, at least for RCC2, in this study that just came out in Nature Medicine, what they did was exactly what I explained, which is basically the question is, can we give neoadjuvant treatment, have biomarker evaluating the likely efficacy of a treatment, and then consolidate? And the gist of that trial, the GU62257, was that patients with clinical T2, T4 had a TURBT, would receive GemCis and 4 cycles of Nivo. And the primary endpoint here would be the complete response. And there was also composite that was a 2-year med-free survival. And so when patients had a complete response, and we'll see how actually this was assessed, and it was up to the discretion of the patient and their preference, they could go actually without any cystectomy, establishing the complete response, and that would be followed by Nivo 8 cycles. If they chose to do so, one patient did, they still could have a cystectomy. If there was no complete response, then they would go to cystectomy. And they also had secondary endpoints, which was the tumor mutation burden and some of the repair genes on the performance and the efficacy of the neoadjuvant treatment. That was the patient characteristics of the 76 patients. Again, same thing, same kind of distribution, reasonably classical, with 60% of CT2, and most of them with a classical urothelial cytology. Now, patients achieved a complete response, which meant normal cytology, normal imaging, and CT0 or CTA. These patients were eligible to proceed without cystectomy and be followed with adjuvant Nivo. Patients not achieving then, as you know, went into cystectomy. And the number of patients who achieved a clinical complete response here was 43%, 33 out of 76. One patient, despite a complete response, went directly to cystectomy. So is 43% much, much better than so far? I would say probably. That's pending that the tolerability is good. I'm only aware, Peter, correct me if I'm wrong, of the Nabucco trial, which is a triplet with Tremi, where they actually had 48% of complete response, but that was pending that 25% were unable to finish due to side effects. So the more you give pre-op neoadjuvant, you tilt the balance towards side effects, and it's going to be a true balance between efficacy and side effects. Now, if you look at the clinical outcomes of those patients, in dark blue, those are the patients who were spared a cystectomy, and this is only among patients who had a clinical complete response. And what you see that is, these are the months now there. A lot of those patients actually did well, although one in the purple actually, despite keeping the bladder, had a metastatic disease. You also see a reasonable amount of patients who achieve a complete response and who presented with local recurrences, required cystectomy, and some actually either pass away or had metastatic disease. And this is why in the commentary by Roger Lee in the same issue, if you really look into the detail, only 34% of patients successfully retain their bladder without recurrence of muscle invasion or metastatic disease. It's better than nothing. So basically, you really give a neoadjuvant trial, you achieve a complete response, and you just monitor the patient, but it's far from the majority. And so that means that we definitely probably need to fine-tune the way that we give the neoadjuvant trials. You also know, and I'm sure most of you have heard, that Tom Powell's presented the EV Pembro first line, clearly showing an improvement by 50%, both for progression and med-free survival. Peter, are you part of the neoadjuvant EV Pembro trial? Yeah. So we have also placed a patient in this trial, to the best of my knowledge, is still ongoing, correct? Have you found, I don't know, maybe just me, I found that the tolerance was a little bit challenging to the treatment. Some patients had really a little bit of a bumpy time. And the second is that surgery was interesting and really fibrotic. And I don't know if you had that experience. No. Yeah. And so I think, the point here is to make is that it's very likely that EV Pembro is going to become now first line. This study will assess that. We still fell short and to really be able to predict, and my final slide deck would have included the tumor mutation burden and the impact of RCC2 and other on the prediction of complete response in Matagalski trial. It actually didn't work. And so the previous assumption that RCC2 would actually drive complete response was not confirmed here. And so we're still kind of short of having a good biomarker. And that's why I think it's so important to continue to do what you guys do, which is basically find targets, move them, and assess them in the neoadjuvant trial setting. Yeah.
Just like with active surveillance for low stage testis or low grade prostate, there's a defined dropout rate, loss to follow up rate. Did you tell us what that was for TMT? And also, how many patients actually went on to cystectomy because they were bladder cripples because of that?
As I said, one patient.
Only one.
Only one. It's fair to say that it may happen, but it's uncommon.
And what about loss to follow up?
In the TMT, I'm talking by heart, I would say nearly no one.
Because it's lethal, right?
Yeah, nearly no one. I think.
So they're all from the GTA in your group? No, they're from all over the province?
I had that discussion with Peter, and I had the discussion last week, and I'll continue. TMT truly is resource draining. And it's not necessarily super easy in our environment where patients travel from far. We have people from Thunder Bay, we have people from Aurelia, we have people from Sudbury at times. And so it's a real commitment for them that have to come down to be assessed. And so I do agree that it really requires a setup, an organization, and just simply saying, okay, we're going to do TMT is for me a recipe for disaster if you don't have the infrastructure to support it. I completely agree. I do agree. I agree, Marty. But on the other hand, I would say that it's going to be more and more difficult to have a treatment where you spare the bladder and with patients who potentially would be eligible, and where the only rationale for not receiving the treatment is because the treatment is not available. And so I think I find reasonable to, at one point, organize our system that allows everyone to get there. It may be wishful thinking, but overall, I do think that in Boston, there's probably a little bit of a bias in the population that can travel to the treatment and those kind of things compared to an overall population. But we have a lot of people outside of the GTA, and I find fascinating that once patients are offered the possibility of keeping their bladder, they'll go the extra mile actually to do it. And so it's kind of rare. They know it's a lethal disease and they continue. Now, what's the future? And I took this from Roger. So the future is truly that we need GUNS trial in bladder cancer. That's my message. And we need to do the same, which is find targets, move them to efficacy, and then moving earlier. And I find that neoadjuvant in bladder cancer, muscle-invasive bladder cancer, is absolutely the prime target to assess the efficacy. We're going to have, the help of also in the future ctDNA, and with Jillian and Alex White, you're well equipped here to do so that in addition to simply the complete response, you also have additional parameters to take. And then depending whether you have ctDNA positive or negative markers, whether you have a complete or incomplete complete response, you move to total bladder preservation or radical, or you actually change the neoadjuvant treatment because you have say that you have a HER2, say that you have a Nectin-4, say that you have this, then you basically then add something pending that it's tolerant. And I will finish here with maybe another way to skin the cat in muscle-invasive bladder cancer. It's not prime there. As we perfectly know, we resect tumors to stage them. At least in our environment, we lose quite a lot of time. I don't know, we have such a time gap between getting to the TRBT and imaging that we often lose at least 6 to 8 weeks. I don't know if you face the same problem. And this is a disease that actually doesn't wait, correct? It's not that like Hannibal and Capu just waiting for his brother quietly to wait for the elephants to cross the Alps. The disease moves. And so Jim established the bladder path in order to see whether cystoscopy and MRI could actually fast track. And they had this trial that was presented, not published yet, where they assigned with reviewers the possible MIBC or an NMIBC setting based on imaging, and actually waived even TRBT in patients who were considered a muscle-invasive bladder cancer. And we're trying actually to see whether this fast tracks the treatment or confirm MIBC. That was in the British environment, although the number of patients you see really small, 14 and 12 here. They actually shrank the the time from 98 days to 23 days. Overall, though, it was from 37 days to 31 days. But what they showed here is that possibly we can actually at one point waive the need for the TRBT. This being said, I think we have to be very, very careful. The scale for the MRI is very, very subjective. There's inter-observer variability, and the MRI is still work in progress, especially if tumors are in the bladder neck or close to ureteric orifice. Marie-Pierre here, yeah.
I mean, issues with MRI and prostate are pretty significant in terms of interpretation and agreement. Has anyone looked at those things for bladder? I mean, obviously the UK has a lot of experience with MRI, and I would assume the radiologists have, a lot of experience, but I can imagine that there'd be significant.
So Bueno in the American Journal of Radiology, and then Séguier, a French author, actually pooled the sensitivity and specificity, exactly addressing the question that you have here. And you see that it really ranges from 74 to 90%, 77. So the wide range. And so, absolutely. Yeah, absolutely. I fully agree. And Marie-Pierre here actually kind of criticized the bladder path. 14 of the first 100 patients randomized were actually diagnosed on MIBC. 5 of those patients deviated from protocol and actually ultimately had a TRBT, and all were found to have non-muscle invasive bladder cancer. So there's a big, big risk here of overcalling muscle invasive bladder cancer. And so, I mean, it's a nice attempt. It's something that should be explored maybe with biomarkers, but at the end of the day, honestly, it's a little bit too early, and MIBC can only be confirmed in 3 of the remaining 9 cystectomies. So it's really a little bit concerning. No, but if you think, I mean, just conceptually, if you think, ideally, you would say that, ideally, you say, you have a patient who comes up, you characterize the tumor with liquid biopsies and the tumor heterogeneity, and you stage it. You predict the response to a neoadjuvant type of treatment, and you set the treatment, and then you consolidate. And so that basically, you remove the need for a TRBT extensive. You basically treat based on the biology. That's, I think that would be the vision. We do now everything because we don't have a great stage without a TRBT. We need the pathologist, we need the variants, we need everything that we know. But the future will be to skip that stage and then to fast track for a disease which is usually moving quickly. I don't know if that makes sense, but I do think that for me is the future, not what we've been doing so far. That's why I said revisiting the way that we treat the disease. I don't know if you share that vision. Yeah. But then you have the tumor heterogeneity. I mean, a simple small biopsy usually is far from representative, and that's where our challenge, and that's where I think liquid biopsies may be of an adjunct, whether it's in the urine. If there was a way to characterize this tumor without having to remove it completely and to stage it, obviously, and I think we're getting there. There's even chemotherapy and radiation in node-positive disease, and I'll skip that to finish. There is a recent paper that was one of my slides by the group in Manchester of Anya Shudbury showing that even in node-positive disease, there's a role for chemoradiation. I find, but that's, and I spoke time and again, I kind of disagree with some of the management in the UK. They don't believe that you need to completely resect the tumor. They treat sometimes multifocal tumors. And ultimately, when I look at their data, completely respectfully, I find that they're really suboptimal. They're clearly suboptimal compared to what I've just shown for select patients. And I don't think that they compare well to cystectomy for the type of treatment, for the type of patients. So I think the future will be to find what's a sweet spot between the British type of management that really accepts everyone for chemorads, our, which is very, very select, and there's maybe a sweet spot that can be defined patients who can be equally candidates. And there's also a widening indication, even for T1 disease now, as I said, for N-positive disease. And there's also a lot of new ongoing trial, and the one that is ongoing now is the triple combo of Durva and Tremi and EV with cystectomy versus cystectomy alone, neoadjuvantly. That's a Volga trial in cisplatin ineligible, same concept. How can we push the envelope? How can we actually end up with complete responses? So I tried to show you that the MIBC field is clearly changing, that cystectomy is not the only tool that we have, that we're absolutely a main component of the trimodality treatment. And I just encourage everyone to use MIBC in the neoadjuvant setting to test drugs the same way that this has been done in prostate cancer. And maybe, as Marty said, with the advantage that we do have complete response. So basically, maybe it's even easier and better than in prostate. Thank you.